Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast today. Today is our 163rd episode of the Codecast. My name is Terry Fletcher. So I usually do a top 10 list, as you know, at the end of each month, the last Tuesday. But I came across kind of a cool article that I also wanted to add to that I found in the AAPC journal. And I thought it was important to bring this to your attention as we get into what's going to happen in 2021. And we're really just figuring out our year end, our month end. And because I also audit, as you know, I thought it was really important at this time of the year to look at ways to improve medical coding and billing accuracy. Because as I'm auditing, and I just finished one with over 1,000 records, I'm finding that there's a lot of transposed numbers. There was misspelling in physicians' names. There were, all kinds of different things that could have been avoided had you really been mindful as a staff member, as a coder, as a biller, as a healthcare professional of your job and making sure that, you kind of take a step back and take stock, take inventory, if you will, and maybe an early New Year's resolution to really help reduce your error rate and to find that accuracy to protect your career in coding. So let's take a look at that and figure this out, because medical coding and billing errors, they can really cause a lot of problems, as you know. Denied and partially paid claims are very costly in dollars, but they also can be costly to you in lost time, in delayed payments. You can find lower quality patient care because, remember, patient care doesn't just stop at the clinical side. It's also the patient's financial well-being. You get angry patients. You can have a reputation for a problem. And then in extreme cases, you could get audits and fines, as I mentioned, which could put your provider's medical practice at risk. And so you don't want to have that. When I mentioned just now a big audit I went through, and I've got several medium-sized ones on my schedule, it's estimated right now, and this is what I'm finding, that as high as 80% of all medical bills contain errors, which means 4 out of 5 claims have the chance of being rejected. It could be lack of documentation to back up the claim, double billing, or just a typo in an account number. But the same result, happens, and that's a denial of reimbursement, and we don't want that to happen. So here are some of my top tips for just really looking at your accuracy. And hopefully it'll help you really strive for that accuracy, but improve your overall goals when it comes to your billing and coding work and what you do. So the first thing, and I mentioned accuracy, you want to strive for that. The best way to prevent claim denials and improper payments is to keep them from beginning or happening in the first place. So before you submit a claim, and I know sometimes the coders don't always have this opportunity, but this is something you really want to just look for. First of all, a non-covered charge. So most common billing errors are claiming that the charge isn't covered by insurance. This can be avoided by verifying coverage and try not to be lazy about it. You can look at a general exclusions section of the Medicare Benefit Policy Manual, Chapter 15, if it's a Medicare claim, because they actually have that kind of information, and that's really important. The other thing is I've noticed that, maybe I'll get to that in a minute when it comes to bundling, and I'll talk to that in just a second. The other thing is missing or incorrect information. This is a big one. When a patient or a provider or insurance information is missing or entered incorrectly, you're going to get a denial. And so you want to really be careful of this really easy mistake because it has a higher likelihood when many people handle one claim. It's kind of like that old saying, too many cooks in the kitchen. So whether you are the first or last person to handle a claim before submission, always check just the spelling of names, the insurance ID numbers, and other identifying information. Is the patient's physical address versus their mailing address where the claim, what is listed in that claim? And that's really important because it depends what Medicare has on file for them or the commercial plan. So for example, for me, I have a physical location and then I have a personal mailbox location for my mail, mainly because our mailboxes where I live tend to get wet and and we get wet mail. So also I have a mailbox for my business. And so I made sure that I have that, separate information, and I don't want things kind of taken out of my mailbox as well. Well, patients do that. They want to have a place that is key and secured, and they can get their mail from as well. So make sure that you know what the address is that they have at listed at their insurer versus what they actually sometimes just put down on their intake sheet. I know that that's a big mistake that we see a lot of times. And if there's a different zip code, that's going to be always a really big deal. Now, double billing. This is something that I see a lot. So the first two, non-covered charge, missing or incorrect information. Double billing, this is a duplicate bill, and this can occur when two providers try to attempt to get paid for the same service, or when you're billing for the same service more than once. So you want to verify that the service has not already been billed or paid, because it's extremely important that you're not paid twice. But if duplicate billing happens too often, it's a red flag. And government agencies may accuse your practice of, trying to fraudulently submit claims and impose fines. So I do get that from practices a lot. So you want to be careful from double billing. Now, it's not the same as a repeat charge as long as you can support it. In one audit I was doing on procedures for a practice recently, they were trying to charge for intravascular ultrasound for each vessel. Well, it's appropriate with the add-on codes, except if you actually read the report and looked at the report detail, it actually wasn't going into each vessel. Each vessel was visualized from one test. And so understand that as well, that there are certain things that you can't capture just because the code says that's what it is until you look at the report detail. Now, number 4 for me, unbundling, and this is very similar to non-covered, but let me just explain, because I was actually having a conversation with a trusted colleague recently, and I was actually surprised because our conversation, it didn't take a turn for the worse, but it took a turn where I had to basically correct somebody that I respect because they didn't have an understanding of the rules when it comes to bundling, at least for Medicare. So here's what you have to look at when it comes to this information. So non-covered means that it's not even part of the policy. And if the patient wants it to be billed, then you don't even need a waiver actually, but let them know that they're ultimately responsible, and there is a voluntary, basically 2-digit modifier you can use for, I think it's GX on Medicare, just saying that we know this isn't covered, but the patient wants to see if, if they want to make sure. And so it's voluntary, and again, it's an exclusion. What bundling means, and I'm going to quote from Medicare. Unbundling refers to a listing of multiple charges that you're trying to get paid separately, but they're already being paid under a single code. So when you incorrectly unbundle services, whether in error or to obtain higher reimbursement, it's considered fraudulent. You want to look, for Medicare anyway, on the National Correct Coding Initiative edits to learn which codes are bundled and when unbundling may be permitted with a modifier. Now, if something is in what we call a B status, remember that means that no modifier is going to help you. It's inclusive of the code, meaning that the payer is saying that the payment has already been made to you. And so you should not be reporting it separately. A perfect example is that new code that came out for PPE, so that personal protective equipment for your staff and anything you have to do in the office to make it COVID ready for the patient so that you're protecting them from the spread of the virus. Well, that 99072 is actually bundled into your office visit. I don't even know why they came up with the code if nobody's going to pay for it. I've been able to get payments for dentists if they want it. There's a couple of payers that are going to allow $15. There's sporadic Blue Cross Blue Shields that are allowing $15 to possibly $50, but Medicare says this is bundled. And so this is inclusive of your E&M service, especially if you received money from HHS under the CARES Act. We already gave you money to take care of this risk and this loss in revenue to build this up. So this is where you have to know if something's in B status. And my argument was with my colleague was, well, I'm instructing people just to bill it anyway because eventually they'll cover. I'm like, no. If it's in B status and you try to bill it and by some chance, a computer glitch happens and you get paid, it means that you double dipped and you can't do that. So make sure you know the status of the claim. If it is in B status, you already got paid. Number 5 is upcoding. Oh my goodness. This is probably the most legal term I ever hear when I do legal work and depositions. So when a code is incorrectly used to reflect a more severe diagnosis or treatment, resulting in a higher reimbursement rate, this is called upcoding. So this is an illegal practice and it's a violation of the Federal False Claim Act, and you have to avoid it at all costs to avoid legal action against the provider. So again, it's when a code is incorrectly used to reflect a more severe diagnosis or treatment. So you're trying to upcode, let's say, to a level 5 when actually the code should be a level 3 or 4. So I'm talking about E&M. So make sure you're not caught in upcoding. Now, undercoding is interesting because this means failing to report the full extent of services or procedures, or undercoding. So it does not help a practice to avoid denials and audits. And actually, not only does it hurt your revenue and loss of revenue for the practice, but the incorrect reporting could result in negative outcomes not only for the patient, but it could flag you if it's different for, whatever specialty you are. Let's say that you're orthopedic and you're not coding for certain things, but other practices are. It could flag not only those practices, but yours as well, as why you're not capturing a service. So upcoding and undercoding both are equally a problem. Number 7 would be insufficient documentation. I know you've heard this before, but when a provider does not document a patient encounter in detail, the coder does not have all the information to code correctly, and you know that. So this often can lead to denial, citing lack of medical necessity. So really have open communication with your physicians and your providers for clarification when you believe their documentation does not support the level of service being billed. And I would even give them, a supportive documentation on whatever level that you're struggling with, and say, this is what this level of service looks like. That way you're not trying to get them to pad their documentation, but you're just letting them know, if this is the scenario in the encounter with the patient, this is what it needs to look like to get that level of service. Overuse of the modifiers. So 2 modifiers consistently get overused. One is modifier 22, believe it or not, and this is called the increased procedural service. Now it's only for surgical procedures. It's not intended with the E&M codes, and CPT guidelines tell us that we may append this modifier when the work required to provide a service is substantially greater than typically required. Now, because they don't really define substantially greater, many providers use their own interpretation. So make sure that documentation supports the use of this modifier, and be prepared for payers to request documentation or need it prior to submitting the claim. There's a couple of commercial plans out there saying that, and MAC carriers saying that if you don't send a report with the 22 modifier, you don't have any choice to appeal it after the fact. And then the 59, of course, because that says distinct procedural service. And we see too many practices and coders and providers trying to use this to unbundle or get every little thing paid. Again, check your CCI edits, check your bundling guidelines, and make sure in this encounter for this date of service, it's appropriate to use that 59 and it's not something routinely done. Otherwise, that's what can flag you for an audit. And then number 9, failure to use up-to-date coding. Believe it or not, it's amazing how many people still have old codes that they use. Code set revisions after January 1st update are common, and so check for code updates throughout the year to make sure you're using the most current codes when filing claims. One thing I just, on the one big audit I did, it was actually kind of surprising. There were actually claims in there for patients where they billed a consult code for a Medicare patient. Now, consult codes have not been available for Medicare patients for 9 years. Why are we still using those? And so we can use them for commercial plans when they don't follow Medicare guidelines. But it just surprised me that that still was being done, which means either it was on their charge master, if they're still using a charge capture or fee ticket format, or that nobody was informing the coders and the providers that there was a change, again, 9 years ago. I had another one where they were doing interventional radiology, and they were doing renal imaging. And under the renal imaging, they basically coded a code that was deleted 5 years ago. And so I said, well, you need to get this out of your system and start using the combined service that includes the catheter placement. So, so instead of the 75724, I said, that's been deleted. You need to use the 36252. And so just realizing that there's still some outdated codes that people are using is really a problem, and you need to make sure that you're updated. And the last one, I would say expenses incurred prior to coverage. What this means is that it is really on you and on your billing staff to make sure that you have verified coverage, because trying to claim payment for services performed before insurance coverage goes into effect will always result in a denial. And always verify coverage prior to a patient's visit, and also have them do the same thing, because you really need to stay vigilant. This is not the full list of errors that can result in denial of reimbursement, but considering the most common coding and billing errors, this is what you want to consider when it comes to assessing your workflow, reviewing your processes, and try and take preventative measures. We also call them proactive measures to keep mistakes to a minimum. So the audits are back out. I just wanted you to have a couple of things to keep in mind as you're looking for, ways to improve your accuracy and hopefully also protect your career as a coder. It's really important, especially as we now get into some of the new rules for 2021, which reminds me, just a reminder, make sure you know that my webinar series is still available on my website at terryfletcher.net, 3-part on demand for the 2021 office and outpatient service code. So make sure you take a look at that. Okay, our question today, let's take a look at our coding question. So our question is an interesting one, and it came from a pediatric practice. It says, which ICD-10 code should I use for medication management on a patient? And this is from one of my West Virginia clients. Well, their short answer is, to your question, there's really no current ICD-10 code for medication management. Now, you can document this using 2 codes, and I would probably begin with a code series Z79, and there's an extra digit you're going to need. That's long-term current drug therapy, and that's the group code there, which allows you to document that your patient is taking one of a number of specific therapeutic drugs. I would also follow that up with a Z79 group, maybe a Z51.81, and that's an encounter for therapeutic drug level monitoring. So it doesn't specifically make mention of the medication management, but it does indicate that your pediatrician has assessed whether the level of drug prescribed to a patient is having the desired therapeutic effect, or whether there's, any kind of adverse effect to the patient. So that is, in essence, medication management. Now, I can't guarantee that every payer will allow the Z codes, but it is a place to start if you're trying to figure out more of a generic situation where you're monitoring medication. So hopefully that helped you. Okay, so when we get into my personal tidbit today, so I mentioned last week that my Steelers are 10-0, and I am happy about that, but there has been an outbreak of COVID positive tests, not only in the NFL, but you've probably seen it around the country as well, and we've had an uptick. And so it's going to be interesting. They've had to move our game 3 times. And I don't know if it's going to happen, because one of our players who we love, our running back, James Conner, who is a cancer survivor, he tested positive this morning. And so that's a problem, because he's high risk. So our prayers go out to him. But this just makes me want to remind everyone to continue to practice safety measures, wear a mask when you can't social distance. And the biggest thing is, even though we're in the holiday season, please try and stay in your pod of people. That means people that you're around all the time that are not, are social distancing, let's put it that way, and are being safe. And then also, I would recommend you get your flu shot. So it's up to you about the vaccine. I know that starts to get distributed next week, and hopefully seniors are going to, really consider taking that, because we need to start seeing that, herd immunity. And they say that if 70% of the country can get the COVID vaccine, then we should start seeing this really just kind of minimize and almost go away by early spring. So we really need to work hard the next couple of months. Anyway, take care, everyone. Make it a great rest of your day, and I'll talk to you next week on the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1, or visit her website at www.terrycoder1.com. www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.